Probably the most common associated thing would be low back pain radiating to the hip area. I mean, I see patients all the time that are referred in for hip pain, and they'll stand up and they'll say, well, where's your pain? That's always how I start. And they point right here. And usually that's not their hip. I mean, that hip pain can radiate into other areas, but as Mark pointed out, hip pain is most commonly, if it's intra-articular, is groin pain, or they'll do, like he said, the C sign and kind of grab their hip. Occasionally they'll feel back here, but usually if it's up higher along the lumbar spine or more in the buttock, I always really try to take an extra look at their spine and make sure that that is not contributing to things, because it's quite common, obviously, low back problems radiating down there. And then we go through the physical examination, similar to what Mark did, usually with hip pain. If you range the hip through a full range of motion, especially with internal rotation, most of the time, like he showed on some of the exams there, it will reproduce their pain. So if you say, does this hurt? I want to know if this is the pain you always feel, and if it feels like it's coming from the same spot where you usually get it. And if they complain of groin pain or pain through here, and I twist their hip and I can see them sitting on the table leaning away like they don't want to do that, that's a pretty good idea that's coming from the hip. If there's any question, I also don't hesitate to get an intra-articular injection as well. And a lot of times in a younger patient who has very mild degrees of arthritis, the injection can also be therapeutic as well. We'll include a little, for less more than just diagnostic, we'll include a little cortisone along with it. And sometimes in more mild degrees of arthritis, like I said, it can relieve their pain for quite some time, and it can be more of a treatment. But once you start to get where things are not responding, or you get a little bit more advanced arthritis, there's really only one good solution for that we have if people reach the point where they feel like they have to have something done, and that's a hip arthroplasty. And hip arthroplasty has been around for nearly 100 years, and it's been done through various techniques through the years. Anterior approach total hip replacement is a similar idea kind of to arthroscopy. It's been around for a long time, but it's only become more popular in the last 10, 15 years as techniques have improved, and some of the adjunctive equipment that we have, like the tables, that we use to do this, that can give us access to the femur, allows us to get in there through a very minimally invasive approach and preserve muscle. So it's not anything that's completely new. This approach has been described for many years, but the frequency of doing it has. So what I'll do here is go through just a little bit of hip anatomy. We just did some of those things here. We've got the femoral head here, the acetabulum, which you discussed already, the greater trochanter, the lesser trochanter, and the femoral neck. And this demonstrates some erosion of cartilage there in that area. So just for those of you that are not familiar with hip replacements, I call this Hip Replacement 101, Steps and Procedures. It's fairly straightforward. I mean, you take the diseased area of the hip socket, is taken with a reamer and reamed out and removed, and then a new cup is secured in the socket. A liner is placed in the cup, then you go ahead and insert a stem in the bone and place the ball in the cup, and you're done. And it seems like a really big deal, but for patients that have significant pain in their hip from arthritic changes, this can be like a miracle procedure. So there's a lot of different approaches to hip replacement surgery. Traditionally, and for most of the older guys, including myself, because it was the most common thing, we're trained in these traditional approaches. Posterior or lateral approaches, most common. Vast majority of orthopedic surgeons that are doing hip replacements use this posterior approach. That's how they were trained. It's an easy way to get into the joint. But you have to go through posteriorly, you have to go through the short external rotators, you have to go through muscle. It's not a true internervous plane, and so there can be problems with recurrent hip dislocation, from hip instability through that approach, and a longer recovery. Although, it works well. The anterior approach, you basically separate the muscles, but you don't really cut any tissues. And having all those tissues intact helps stabilize the joint immediately. We don't have any protected weight bearing afterwards. My usual instructions to the patients as far as rehab is, don't do anything stupid. Get out there and just start walking, start doing what you want to do. And there's faster recovery and less pain. And there's some references here if any of you are interested. So once again, the traditional approach oftentimes will run up the side of the hip like this and toward the back, and vary anywhere from 4 to 12 inches long. The 4-inch incisions through that area are pretty minimal. There's pretty good visibility of the joint. Hospital stays a little longer, and it's certainly the most widely used approach. The anterior approach is an incision made more on the front of the leg. It runs typically from about here to here along the side of the leg, and the surgeon works down between the muscles without detaching them. And like I said, it's a true internervous plane. I'll show you on some animation later where the tensor fascia is innervated by the femoral nerve, and it goes between the gluteal nerve. So it's through those areas there, and you're not splitting any muscle off. And this is a picture of the table that Mark was talking about here. This is a table that allows us to take the hip through multiple positions and get access to that hip easily and safely. As you can imagine, it's pretty easy to pull the hip to the side and get to the acetabulum through the front, but to get a line of sight down the femur to put that stem in is challenging. And this allows us to drop the leg down, lift up the femur, rotate it around so that we can get that straight shot down the femur to put that femoral stem in. And people do these surgeries without this table, but the safety profile, it's much more challenging, and the safety profile is not quite as good. And so for a little, commercial for Providence Centralia Hospital, we, within the last 6 months, acquired one of these HANA tables here, and now are able to do this with this HANA table. And now, now both myself and Dr. Morshigi can use these tables to do these procedures. And we're one of the few hospitals in the area that has it. St. Peter's doesn't even have one of these. So it's a pretty handy tool. So once again, muscle attachment is preserved, there's less tissue disruption, a little bit faster rehab, potentially less pain, and fewer restrictions during recovery. And there's a lot of comparative studies out there. Here's one at about 6 weeks. You can see that this Harris hip score and the pain score are both fairly equivalent. So they're pretty good at relieving pain pretty equally. Patients come out and say, my pain's gone, I'm happy I had it done. But where you start to really see the difference here at 6 weeks is the ability to walk 6 blocks, stairs without a banister, socks, putting on socks and shoes. You can see a much bigger discrepancy between the two procedures there. Now, a lot of these things will even out. But here's the key differences even at a year in a lot of studies. Once again, the pain scores look pretty good. They're equal procedures in that area. But if we start to look critically at what the activities that our patients can do, there's still a lower percentage of patients that are able to feel like they've really returned to completely full activity with the other approaches versus the anterior hip. And I can tell you from my own personal experience, I've been doing hip replacements for 25 years now, and mainly done one of these other approaches, an anterolateral approach, and I'm always very happy with how my patients did. I thought everything was going great, but since I've started doing this anterior approach, I've had patients who I've done the other hip one way and done this hip this way, and what I thought was so awesome before, and the patients were really happy before, they say, what did you do this time, doc? It's like, this is amazing, this is way better than last time. What did you do differently? And they go through the explanation. So I've seen it even in my own patients. Let's see here. So here's the video. This is just a quick demonstration of how this takes place here. This is the tensor fascia muscle. We make an incision in the skin over that and then divide between the tensor fascia and the rectus to avoid the lateral femoral-cutaneous nerve and get down between this internervous plane right here. A couple of circumflex vessels across the front that we try to avoid and coagulate. And you can see the angles here. And so this just basically goes through sort of what we do. We get in between that internervous plane. And this approach is new to lots of surgeons because it requires a lot of soft tissue landmarks rather than the old orthopedic surgeon go to bone and stay there. You're really trying to preserve the soft tissue. And so this visually is a lot difficult for a lot of orthopedic surgeons who are not used to doing it this way. And it takes a while to learn how to do this. Cut the capsule and just peel the capsule back. So you really haven't detached anything at this point except just the capsule. You're opening that up. And then we repair that at the end. Retractors go in. Obviously, specialized retractors are very important to allow you to see down in there. You can remove the excess labrum and osteophytes and the bone around the acetabulum through this approach there. And then there's a couple of ways to do this. Some surgeons do like what is done here and dislocate the hip first to complete the releases. And it shows using a skid and a corkscrew here. Obviously, we're not worried about the condition of the femoral head anymore. We're taking it out. And then completing the releases around there.
That hip joint just looks like it's still fine.
Yeah, it does kind of. I think he was a little premature on this hip. And then the hip retractors are placed along here, and the femoral neck cut gets made with the oscillating saw.
How far down will the stem go into the femur?
It depends on the style of the stem. On average, probably about 8 inches. Some of them are a little shorter. Depends on the brand and what the type of fixation is used. Then you got a good view of the acetabulum here. Got the retractors around there like that, and this is where the shaping of the acetabulum comes in. A reamer comes in like this and gradually enlarges and shapes the acetabulum to the size of the metal cup that you want to put in. Then the metal cup typically gets press fit in with porous coating that allows bone ingrowth into the socket, and then the plastic liner. And then here's the tricky part, the femur. So you can see how the table allows us to really rotate the leg way out. A special bone hook goes in underneath the femur. There's a mechanical lift on the bed that allows you to lift the femur up, and then along with releasing some of the tissue along here, like you'll see in this animation, it allows you to elevate the femur, hopefully far enough out of the hip to get a straight shot in like this to get down the canal, once again without really disrupting any of the muscles. The femur is broached. There's a special kind of a reaming tool that takes away bone and gradually enlarges the slot for the stem. And one of the advantages of doing this particular technique that I didn't really mention before is our ability to use X-ray to make sure we have perfect size and position before we commit to it. And the typical lateral approach is very challenging to get an X-ray machine in the room and image through the instruments and things like that that are holding this. These patients in a supine position on this table where there's nothing around them, I can bring a fluoroscopy unit, a C-arm in the room, and image the hip. And I practically spend as much time imaging the hip and making measurements to make sure my leg lengths are exactly equal and the parts are the right size that I do sometimes doing the hip replacement itself. And then once you're happy with the trials, you put the real thing in, image it again, and then reduce the hip. So that's another huge advantage to this particular way of doing things, is it allows for really easy, accurate imaging of the hip. You can see this lift I'm talking about here that helps get the femur up and out. And then the trial ball comes off. Once you're happy with the leg length and the stability, you can check the stability there. You can look at the leg lengths on the X-ray and compare side to side. And then the actual implant head goes on. I usually use a ceramic head, which that combined with high molecular weight, high density polyethylene has very low wear characteristics. That's about it. So once again, the main advantages are the muscle sparing approach, internervous plane, lower, not as many restrictions post-operatively, and hopefully the ability to more accurately and reliably reproduce our implant positioning, which is real important for outcomes. Any questions about all that?
Is there a size limit on that, like a 500-pound patient?
There kind of is. I mean, there are some surgeons, if you talk to Dr. Mata, who's one of the godfathers of this procedure in this country, he's still practicing down in the Santa Monica area. I mean, he'll probably take almost anybody. But I mean, if you can imagine trying to get the patient supine and they're trying to get through this like this, the belly and the soft tissue can be in the way. But in some ways, depending on how you look at it, the hip is actually closer to the surface of the skin in a heavy patient through the front than the side. I mean, you can be in a really deep hole through the side too, and I have many times. There can be 6 to 10 inches of fat on the outside here or more, and it's hard to sometimes do it through a side incision as well. Actually doing it through the front is almost a little easier in that way, except for the access to the femur where that abdomen can really get in the way. So we'll use tape and other things like that to literally tape the abdomen up and over and out of the way to try to still get access through there. So I would say from my practice right now, I am being a little selective. I'm not taking all comers. And so if somebody is over, and I don't just look at BMI, I actually just basically have them lie supine on the table when I'm doing my examination and see if I can feel their anterior superior iliac spine. If I can feel the anatomy and can get my landmarks and I can feel like I can get it up out of the way, I'll go ahead and do it. But not everybody, at least in my book, is a candidate for this.
Does this work in traumatic hip replacements as well as?
Oh, sure. I think it's actually a great way to, I've started doing my hip fractures this way. It's not really a traumatic, but it's kind of like a traumatic hip replacement. If you think about it, what a better person to save the muscle in than a 85, 87-year-old little old lady who just broke her hip. And you don't have to worry as much about stability. So it's a little bit more there's a little bit more hassle factor there than just kind of cutting down and slamming a hip in. It's not a 30-minute case anymore, because I go in there, I use the same techniques that I do for the total hips, image it, make sure the hip lengths, leg lengths are equal and everything. But yeah, I do this a lot of times if I can for my hip replacements, or my hemiarthroplasties for hip fractures as well. Any other questions about that? All right. Well, just wanted to give you a little introduction to something that may not be all aware of. It's not a, there's not that many guys doing it this way. There's a few guys up in Seattle. There's one, Dr. Halpin in Olympia used to do these pretty regularly. He was very good at it, and I scrubbed with him many times, kind of in the process of trying to learn how to do this. But he's since retired. So, yes.
How many patients have you done?
Probably anterior now about 20. So it's not a huge volume yet, but I've gotten to the point, it's got to the point where I feel pretty comfortable with it. It's not something you want to just jump into. I spent some time working on this for a while before I started doing it on my own. I went to several courses, worked on cadavers for a while, went to operate with other surgeons, and had a couple of those surgeons come to Centroia to help operate with me for a while. So I really wanted to make sure I did it right. I wouldn't call myself, the world's expert in it, obviously, with only 20 cases under my belt, but I've been doing hip replacements in general for 25 years, and I've done it through the anterolateral approach, which is actually only a slight modification of this. So I'm used to seeing patients from this angle and approaching the hip from the front. So it wasn't as probably a big a transition as for me as it was for some surgeons who are used to going through the back in the most common way.
Are you going to apply this method for most any hip replacements now, or are you still going to be kind of selective?
Yeah, no, like what Dr. Strobach pointed out, I think there's still, occasionally we get 400 pounders, 300 pounders in here, and at this point I'm still telling those patients, look, I think there's some risk to that. If you can't get good access to the femur, there's all sorts of x-rays out there of bad complications of people fracturing the femur, and obviously that can happen even when you're in another position, but I still am selective at this point and try to make sure we do, first off, do no harm. Any other questions? Yeah.
Dr. Zeckman in Olympia it's called SuperPath. Is that also the anterior approach?
No, that's different. That approach also has been around for a while, and it's kind of billed as a minimally invasive approach for surgeons who are used to doing it posteriorly. So it's a little bit of an easier transition to go to, and I'll explain what that is briefly. It's an easier transition for surgeons who are used to doing the old posterior approach to do it this way, because you make the same incision basically for a posterior approach, but what they do is instead of, it's still not a true internervous plane, but they go down and try not to detach any muscle, so they're doing a muscle split. So they split the gluteus and divide the gluteus muscle, which there's obvious risk potentially for denervation of the gluteus when you do that. And then once they get down through the gluteus, they go through the gluteus medius as a muscle splitting approach. They're not, where I did the traditional anterolateral, you actually take a portion of the gluteus medius and the gluteus, off of the trochanter and detach it and then reattach it later. So they're not actually detaching anything, but they're actually splitting the muscle belly and going through the muscle belly straight from superior, cutting out the capsule superiorly, and then it gives the insertion point to the femur is really great because the patient's in a lateral position and it's the position they're used to, and you can shoot right down the femur. But the position for the acetabulum is a lot more challenging to see where that is. Some people have to use what they call 90-degree reamers, where you go in, the reamer is completely offset, and you kind of shove it in from the side. So it has some of the it's billed as a kind of a procedure that has some of the advantages of the anterior approach in that you're really not detaching any muscle, but it's a little easier for surgeons to transition to that have been doing it posteriorly. The downside is it's, potentially you're still having to go through the muscle instead of just going between a muscle plane. This one, the rectus femoris is here, the tensor fascia is here, and you pull those apart, between the normal plane between them, and you're right there. You're not actually dividing the muscle belly. Does that make sense? Any other questions about that? Looks like you might have a list there, so I'm happy to answer all of them.
So the anterior approach is probably a little superior.
I mean, that's how I feel about it. I think because of those reasons I just said, you're not cutting through any muscle bellies. You can see the muscle fibers. You can take your finger and you can dissect down. You can pull the muscle bellies apart. You can use blunt retractors. You don't have to actually cut, but you're basically digging through the belly of the muscle and ultimately pulling it apart. And there are nerve fibers that cross across the muscle bellies. That's how muscles get innervated. So there is a little bit of risk for a little bit of denervation there, but most of the people that do it seem to think it works fairly well. So that's just kind of my opinion on that. I think for those reasons. It's an approach that's familiar because you're on the side. One of the other downsides, I would say, speaking of size, for the anterior approach is the incision does have a tendency to cross this abdominal crease right here a little bit. So you got to be very careful how you handle the soft tissues. And sometimes people, you can imagine if they've got a little bit of a pannus there, will get a little bit irritated and get a little incisional breakdown right there at the top of the incision. So far I haven't had any problem with that, but you can see that sometimes. And that's not something you really see as much if the skin is on the side. The skin on the side of your hip is like a piece of leather, and it comes together really well. Anything else?
An acquaintance of mine, fairly young, had hip surgery, and he had problems for a long time before he had his hips worked on. Mm-hmm. And the first one went well. The second one, he had maybe the socket or something, and the bones fused together. He didn't get specific, he didn't know that. Yeah. And they had to break the bone or whatever.
It sounds like, so one side went well, but then he had both hips were bad. It sounds like what you might have been talking about, what you might be referring to is something called heterotopic ossification. Heterotopic ossification is where bone forms abnormally in tissues where it doesn't belong. And some people are more prone to that. There's a little bit of genetic involvement. Also, the more trauma there is to the joint when you're doing the surgery, the more trauma to the muscle and the more bleeding into the muscle and all those other things like that, the more likely it is to do that. There have been lots, so some people will get it really bad. Usually, I've never seen a patient that had it so bad it had to be taken down, but there's a lot of reports of that. And basically what ends up happening is, the bone, so much bone forms around the hip and the soft tissues, it really is painful and restricts the hip range of motion. There are some ways you can prophylactically help prevent that. Some people describe ionizing radiation as a way to do that, but what works almost as well as anything else in most patients, especially if you've been very careful to provide at least the least amount of trauma possible during the surgery, is non-steroidal anti-inflammatory medications like ibuprofen or diclofenac or Indocin is kind of the classic one, indomethacin, for 4 to 6 weeks after surgery will significantly decrease the risk of that forming in the tissues. And so some people are just more prone to it than others.
Do you recommend doing both at the same time, the anterior approach?
Some people, I've never done it that way. It can be done both at the same time, absolutely. That's one of the advantages of obviously doing it in a supine position on this table. You really don't have to go through a big repositioning process. If I've got somebody in lateral position, I want to do them at the same time, they're on their side, I've got to completely turn them over, flip them back over, and all this other stuff like that. If I want to do them at the same time here, it's very simple. Just once you're done, you've dressed one side, you take the drapes off, re-drape, and just walk to the other side of the bed. And so it can definitely be done. Some people do it. I just have not had any patients, to be quite honest, that their hips were equally bad enough to warrant doing it that way. All right. Thanks for coming.